Good afternoon. I will be presenting a retrospective analysis of refractive change following encircling buccal removal or division in infants who underwent buccal for retinopathy of prematurity. High incidence of myopia is well known in children with retinopathy of prematurity. Encircling scleral buccal induces myopia, and many authors recommend its removal post successful reattachment. The purpose of our study was to assess the change in refraction post buccal removal or division and assess the myopia, progression of myopia in these eyes. So we retrospectively analyzed records from 2011 to 2015. We included 18 eyes of 13 infants who underwent encircling scleral buccal with subsequent removal for stage 4 ROP and had a minimum follow-up of 2 years. Non-parametric tests were used as the data was not normally distributed. So for scleral buckling, all the 4 recti were tagged and partial thickness scleral tunnels were made and encircling band was passed. Refraction was done 6 weeks following the procedure. Through a limited conjunctival opening, buccal was either removed or cut after successful reattachment, and refraction was repeated 6 weeks following this procedure and at every subsequent follow-up. Mean birth weight was 1.4 kilogram, gestational age 29.7. They presented at a mean post-menstrual age of 40.4 and operated at 42.5. Median age at buccal removal was 14.9 and median follow-up was 6 years. There were almost equal number of males and females. 8 of them underwent unilateral encircling buccal placement and 5 of them underwent bilateral surgery. Prior to encircling scleral buccal, the eyes also underwent laser, anti-VEGF, or a combination of laser and anti-VEGF. Almost all of them received supplemental oxygen and half of them received phototherapy. Anatomical success of our study was 94.4%, and that reported in literature is from 67 to 100%. Almost more than half of the patient had a visual acuity more than 6/60, which is much more than that reported in literature. There was a decrease in myopia after removal of buccal, as we can see there. Median spherical equivalent at 2 years was -7.25 and at 4 years -8.25. We also compared our median spherical equivalent at 2 years with a study published from our institute in IJO, in which they compared the median spherical equivalent at 2 years in eyes that underwent lens sparing vitrectomy with laser, and the two study groups were not different in terms of mean birth weight, gestational age, or post-menstrual age. We did not find any statistically significant difference. Similar results were seen at 3 months, 1.5 years, or 2 years. So the median change in our study was 1 diopter and mean 1.21, which was statistically significant. Prior to this, there are only 2 case series that report change in refraction following buccal removal in children with retinopathy of prematurity. One was done by Chow et al., in which they reported a mean of 5 and a range of 2 to 10.5. Other was done by Choi et al. This was a prospective study in which they also analyzed the axial length, and they said that the axial length either remains the same or increases post-buccal removal. So this change in myopia is probably not because of axial length, but anterior segment parameters like corneal curvature or the shift anterior chamber depth. In our study, no retrospective, biometric analysis was done since it was a retrospective study. The mean change was 1.21 and median 1, range -1 to 9. We found a significant correlation of age at encircling scleral buccal with the change in spherical equivalent. That is, the children who presented late had a more change in spherical equivalent. We also found more induced myopia after scleral buccal in these children. This can be because they required higher indentation when they present late, but there was no statistically significant correlation of age at surgery and interval between the two age at removal and interval between the two surgeries. So we compared the refraction with the other eye. In unilateral encircling scleral buccal, the eyes who underwent encircling scleral buccal, 5 had inoperable stage 5 ROP in the other eye. In the other 3, 2 had an isometropia. Maximum anisometropia in bilateral encircling buccal was 5.25. So to conclude, removal of encircling scleral buccal does cause significant decrease in myopia, and it may lead to better functional results, but a prospective study with biometric analysis would help in better understanding of its effect on ocular growth and refraction. Thank you.